First of all, welcome to this epidemic ethics additional webinar. Delighted to see so many people here today. Very much looking forward to this discussion on this important and timely topic. This is an additional webinar over and above the usual epidemic ethics program because we thought this was a topic that needed discussion and needed discussion now. So very much looking forward to that. So the topic is, well, the title of the session is COVID-19 vaccination boosters, when and why. The idea here is to look at the ethical considerations about the provision of booster doses, to look at the arguments that people provide for giving them or for not giving them, and then to have a discussion about those issues. To say who I am, my name is Mike Parker. I'm the director of a centre called the Ethox Centre at the University of Oxford, which specialises in looking at ethical issues in global health and with partners in Africa and Southeast Asia. So delighted to be here. So our first panellist is Professor Sir Andrew Pollard, who's Professor of Paediatric Infection and Immunity at the University of Oxford. He's also the director of the Oxford Vaccine Group. He chairs the UK Department of Health and Social Care's Joint Committee on Vaccination and Immunisation, JCVI, and is a member of the WHO's Strategic Advisory Group of experts. His research includes the design, development and clinical evaluation of vaccines in the UK, Asia, Africa and Latin America, and most recently in 2020 he was the chief investigator for the clinical trials of the Oxford AstraZeneca vaccine, and he received a knighthood in 2021 for services to public health. So very great to have you with us, Andy. Our second speaker is Dr. Kate O'Brien. Kate is the director of the Department of Immunisation, Vaccines and Biologics at the World Health Organization. Prior to this, she was a consultant paediatric infectious disease physician and professor of international health and epidemiology at Johns Hopkins Bloomberg School of Public Health, where she also served as the executive director of the International Vaccine Access Center. Her academic career focused on conducting large vaccine clinical trials and the epidemiologic studies related to vaccine development and optimization, working with the American Indian tribes in the US and many countries in Africa and Asia. Prior to joining WHO, she served on the WHO's Strategic Advisory Group of Experts, SAGE, from 2012 to 2018. Great to have you with us as well, Kate. And our third speaker is Dr. Yodi Alakija, who's co-chair of the African Union Africa Vaccine Delivery Alliance for COVID-19. She's also the chief strategist for Convince Africa and founder of the Nexus Hub, which is an innovation center and emergency response unit for the West African region in Abuja, Nigeria. She's a published researcher and in collaboration with the WHO and UNICEF has led multi-country behavioral health surveys across several nations in the Pacific region. Great to have you with us as well, Yodi. So don't want to take up any more time, so I will now hand over to Andy, who's going to be our first speaker.
Thanks very much, Mike. I thought perhaps just to set the scene, to just reflect on where we are at the moment. So here, as we sit at the end of September 2021, in the midst of this pandemic tragedy that humanity has been facing, we've reached about 4.8 million reported deaths from COVID-19 over the course of that period. And of course, we know really to a large extent today who those people are. We know that the majority are older adults. They include individuals with other types of health conditions. And sadly, also a number of them are healthcare workers who've been in the front line of the fight against the pandemic. And over the course of the last 18 months, through the I think quite remarkable efforts of people working in industry and in academia and clinical trials, we now do have tools which are available, vaccines that can prevent the vast majority of the deaths. And I think one of the first things which is, I find very concerning, is that when we look from a global ethics point of view from as public health experts, is that many months ago we already had enough doses produced that could have prevented a majority of the deaths that have happened over the last several months, and certainly those which will happen during the rest of this year. And the problem, the reason why we're not really stopping those deaths at this moment, is that the doses that we have are very much focused on a relatively small number of countries. And if we just look at what that sounds like in numbers, if we go back to June when the G7 met here in the UK, there were many pledges by those G7 leaders of new vaccine doses being made available, particularly to low-income countries through COVAX. But the problem there wasn't that the timescale of those donations being made available wasn't clear. And what's happened since June is that another 1 million people have died between those pledges and today. And if we project forwards towards the end of this year, the end of December, it's thought that somewhere around another 600,000 people will die. And as I say, the vast majority of those deaths were preventable because we have enough doses in the world that could have been targeted at older adults and people with health conditions and healthcare workers. So this is really the big ethical dilemma that we have already failed in that aim that there has been to try to protect the world using vaccines. We do have a constrained supply for sure, but still the vaccines have been immensely powerful where they have been used in countries in Europe, in North America, and many other countries where there's high coverage today with 2 doses. Amongst the vaccinated, there is protection that is somewhere between 80 and nearly 100%, depending on the segment of the population. And particularly amongst the younger adults, those under 65, and those healthy individuals, the vaccines are giving close to 100% protection, certainly well over 95% protection. And if we have today extra doses of vaccine, if I had an extra dose of vaccine in my hand and I was to try and get the maximum benefit out of that dose, it would not be to give a 3rd dose to people who already have very high levels of protection. It would be to give that 3rd dose to people at this moment who have not had any, and particularly if they're in those risk categories of being older adults or those with the known risk factors that we've known about for more than a year. But of course, that is problematic because a lot of the decision making, it has to be made at a domestic level. We don't have a global government that is trying to look at what's the best way to manage the whole world. We've got, I think, good ambition, which came last year through COVAX and from a public health perspective of how we might best protect the world. And if that roadmap had been followed, today we'd be in such a different place. But the difficulty is really for the domestic politics and domestic public health, where having relatively small gains in benefit by giving booster doses in countries that already have 2, still is driving policy decisions rather than that global moral framework that we should have, which is to make sure that people everywhere are protected. And as I said, if we don't change that view, then we really will see many hundreds of thousands more deaths in the remaining months of this year. Maybe we are already at a point where the global political landscape is clear that until there is sufficient supply, then it's going to be very difficult to change the direction of travel that there is already. What does this mean for future pandemics? If we were here again in the future, would we be in a better position where we could have put the structures in place to make sure there was equitable distribution? Or will we find that because of the experiences of this pandemic, that people will be even more entrenched in their view? And I think for me, this is one of the real questions that come out of today is, if we accept that there is a major moral failure in the distribution of vaccines in this pandemic, what would we do differently to avoid that in the future? And I'll end there with that question.
Great, thanks very much. Yeah, really important question. Thanks very much, Andy. Yeah, Yodi, are you happy to go first? Go next.
Sure. Looking at the title of the webinar, and thank you very much to Andy, for his framing of the issue. There's something that he said where he talked about us currently not having a global government, and I would add to that a global government for pandemics. And really that is part of the key issue here that I see as we're talking about, to boost or not to boost, to distribute vaccines equitably or whether we do indeed wait for this global political landscape and what they're signaling, which to me is quite clearly that it will be supply and not morality or ethics that drives global distribution. All the right noises have been made. They have been made last week at the UN General Assembly special summit hosted by President Biden in the United States. Even more promises were made, but what we're failing to see in the low-income countries of the world, mainly, particularly in Africa, that I of course serve as chair of the Africa Vaccine Delivery Alliance. What we don't see is a plan for action. What we're not actually seeing is more than a drip drab, a trickle of vaccines on the ground. And when we talk about equity and we talk about this more wider justice and equity conundrum, it isn't just vaccine equity, we're talking vaccines today, but when Andy spoke earlier about the number of deaths and the sort of the demographic of people that we very sadly lost to this, I think we're way undercounting them, and also we're not taking into account the excess deaths in many low-income countries of the world where people have died for lack of treatment for other diseases when hospitals have been totally overwhelmed, but even the lack of oxygen, the lack of testing, which doesn't tell us just how many people have been infected in parts of the world, and which also begins then to speak to the development and evolution of this virus and to the development of various variants. So I would argue that first and foremost, this is not and cannot be considered an ethical debate. There is no ethics about vaccinations. A debate would indicate that there is a time for a prolonged discussion on this issue, and that is something in a pandemic that we don't have. And indeed, it is from an immense point of privilege that we, myself included, are able to really sit here, be on this online and discuss the distribution of what are effectively life-saving measures for billions of people across the planet. This is an individual versus the collectivism. For me, individualism versus collectivism has become the core of this debate. Whether you're talking to people in the United States who are refusing vaccines, or in the UK or other parts of the world where vaccines are absolutely in surplus and they're refusing to take them, or you're deciding whether to give that third dose that Andy very, very, very clearly said would be far more useful in the arm of somebody who is in a low-income country of the world where they have yet to receive a single vaccine. Burundi in Africa is one of the countries that is yet to administer a single vaccine. And yet, yes, there is political responsibility to be taken for that from African leadership, because initially the president and the leadership of that country refused to accept that COVID existed. However, we as a collective, I think, we're in a time where the world has become the individual versus the collective, individual people, individual nations, and individual states. We're forgetting that the communal nature, the collective nature of our humanity is what our common humanity is what is going to keep us all alive. And I would argue that the protection we receive from vaccinating populations, boosting rather than boosting our own, extends much further into the future than the domestic vaccination programs that seems to be capturing the sort of nationalistic political agenda at the moment. I cannot agree more with Andrew about the fact that we have to look further than the domestic agenda. He has raised a great point about, what do we do for future pandemics? But one would also have to argue that we're at this stage in this pandemics where we can still engage in this debate, but we need to move quickly and move away from this anti-science nationalistic view of protecting ourselves and not the others before we are no longer able to, in case there is indeed a further evolution for this of this virus. I'm going to stop there because I know we don't have much time, and happy to answer lots of questions and get into the debate as we go on. Thank you.
Thank you very much for that. It's really lots and lots to be thinking about here. One of the things that's immediately apparent is that there are some short and medium term questions here, and there are also some longer term, really profound changes that need to be made. So we'll come back to that. Just I'm going to pass on to Kate next, but just before I do that, can I remind you that if you do have a question you'd like to ask, please can you put it in the Q&A function at the bottom of your page, and I will try my best to get through those. So yeah, over to you, Kate.
Okay, good. This map shows you the countries that have not even achieved 10% coverage. So this is 56 countries around the world, and those countries account for a fifth of the world's population. This is not a small representation of the world's population. So although we're here to sort of talk about this from an ethical perspective, this is the issue around the equity is not just a moral issue. It's actually a science, epidemiologic, and ending the pandemic issue. The point I want to make here is the pandemic is not over, and it may be over in some ways, for some people in highly immunized countries or people who are immunized, but this just shows the cases and the deaths. We are still well into this pandemic, and this is not a pandemic that is on the downswing. So one of the things that keeps coming up is, well, how does it make any sense to withhold from some groups a booster dose that is surely going to be of high benefit to them in service to doses that are going to other countries? And I think we also have to anchor on this point, which is that the whole intent of COVID vaccines was to prevent against the severe end of the disease spectrum. And these vaccines are holding up very well over time against the severe end of the disease spectrum, including against the variants. So this just shows the maintenance of the effectiveness against hospitalization, arguing that even without boosters, we're getting the effect that the vaccines were intended to. Now, it's true that vaccine effectiveness against a milder end of the disease spectrum is starting to wane. That's happening at a time when variants are coming in, especially the Delta variant. But this was never the intent of the vaccines. This is not the thing that's driving the pandemic response, and it's not why the vaccines are being deployed worldwide. And so, do we really care about how many booster doses are being given? Well, this just shows the countries that are already providing booster doses. On the left, 30 countries. There are 10 additional countries that have plans to deploy booster doses but haven't started yet. So that's, even at this very early stage, 40 countries that have already made this decision. And that accounts for a substantial number of doses already. So over 20 million doses have already been administered as boosters. And I want to sort of give you some grounding of what that actually means. We only need 200 million doses in order for every country to achieve 10% coverage. So this number of booster doses that has already been administered represents 10% of getting towards that minimum coverage level. This is my last slide, and I want to point out the equity issue here. We're all working towards ending this pandemic, and that means getting back to full social and economic recovery. And in order to do that, we need to address the health impact of the pandemic. There were enough doses administered worldwide on May 19th that would have, if they had been equitably distributed, immunized 10% of the world's population in every single country. And in fact, yesterday was the day when the number of doses that had already been administered worldwide would have accounted for 40% coverage in every country if they had been administered equitably. And we would get to 70% coverage in every country by the end of February, again, if the doses had been administered equitably. That would have been the smart epidemiologic thing to do, the smart virologic thing to do, and it would have been the moral thing to do as well. The world produces somewhere between 1 billion and 1.5 billion WHO emergency use listed vaccines every month. There is enough vaccine to go around, but it has to be deployed in a way that addresses the equity issue and actually gets at the health impact. There is almost no scenario where a booster dose to somebody who's already received their primary immunization will outperform a primary immunization in high-risk populations that have not been immunized yet. There's just no scenario, barring a few, where you're immunizing, young children. But there's no scenario where the impact of that dose will outperform giving a primary immunization. So from an ethics perspective, but also from an economic, from a health and from a social perspective, the justification for the booster doses does not stand up to what the aim of the world is in order to end this pandemic. Thanks.
Great, thank you very much. That's really, really important and interesting. And so let's open up for discussion now. Maybe you could stop sharing your slides, Kate. We can see you all. I've got some questions. I'm going to go through the Q&A, but I've got a couple of questions I think it'd be worth to ask to begin with. So clarification maybe. So there was an article in the New York Times at the weekend, which was sort of saying the companies were saying, as you said, there are enough doses. The problem here is not an ethical one; it's a regulatory and logistic problem. And I just wonder, that seemed to. So is that? Do you want to sort of maybe? Does anyone want to respond to that? So they were sort of saying, it's not about will, as it were. It's sort of to do with regulatory structures.
May I?
Yeah, go for it.
I would like to respond to that. I think that is absolute balderdash, if you forgive my language. That is absolute balderdash. I think Kate made it very clear that there were enough doses in May, I believe, that to have gone to around the world, to have vaccinated 10% of people around the world. The issue is not regulatory, it's not logistics, the issue is greed. The issue is greed, and it is individualism, it is nationalism, and it is politics. Because if the world came together with the will and the collective determination, the same as the allied nations and NATO and the US and UK, etc., used when they wanted to get endangered people into their minds out of Afghanistan, out of the way of the Taliban. If we came at distributing vaccines around the world with that same energy, if we brought that energy, we brought that purpose, and we brought that determination to the table, we would have vaccinated 40% of the world's population by yesterday. The reason we're talking about booster doses is because it appears that some lives are worth more than others to the minds of some people around the world. It is not, as both Andy and Kate have said, an ethics debate. It makes me almost, it makes me quite mad when people will make these excuses and talk about the logistics. They'll tell you that in Africa we don't have the cold chain, so that's the problem. No, we could have the cold chain. We in fact do have the cold chain if the world was prepared to do what is right in this moment, and if the world thought of things in an equitable manner and considered the fact that we need to end, as Kate just said, end this pandemic once and for all. The booster doses are a political gimmick and they're a stunt. Right now, the science does not hold up, but it is what this current nationalistic, populistic rhetoric wants to hear, and that is what we're getting. Over.
Thanks very much. I mean, does anyone want to?
Maybe I could just jump in.
Yeah, go ahead, Kate.
Yeah, on the regulatory side, I really think that we need to actually be honest about what's happening on the regulatory side. This is not a regulatory problem. There are 7 vaccines that have WHO emergency use listing, and there are more coming. And what that means is that countries around the world have authorized the use of vaccines in their country at record speed. This is not an obstruction from a regulatory perspective. That's the whole intent of the WHO pre-qualification and emergency use listing procedure. What I think actually the evidence shows is that the contracts for the delivery of the vaccine that were entered into by the COVAX facility, by the African vaccine AVAT as well, and it's true for other countries, those contracts and the expectations that were made about when the doses were going to be delivered were not met. And so I think the question here is actually a different question, which is, there clearly has been over 6 billion doses of supplied vaccine, and the only entities that know how the choices were made about where to allocate those vaccines to which countries are the manufacturers. They're the ones who hold the contracts, and they're the ones who know what their obligations were to a variety of entities. And there were many decisions made along the way by many different people and many different entities. And I think where the focus has to be is moving forward. The priority has to be deployment of the doses to COVAX and AVAT to get those doses to the countries that are very far behind. And those are countries in Africa and some other countries outside of Africa. But this is not a regulatory problem. There were adequate doses that were contracted to actually be much further along in this problem, and the doses did not come.
So, yeah, picking up.
Just I can make a very brief comment. I completely agree that there's no regulatory hurdle for the reasons that Kate has highlighted. You know, I think there is no doubt that some infrastructure problems will exist in some countries. But my experience in talking to public health officials, whether it's in countries in Africa or Latin America or in Asia, is that they are nowhere near to the point where they can't deploy the vaccines. What their main problem is supply. It's not the capacity to deploy.
And Yodi's comment in the chat about, you know, whether there's ever going to be any accountability, as it were, whether it's going to be possible to look at those contracts and hold people to account. That's obviously an interesting question, but it presumably fits in with your point, Andy, about a new governance landscape where people can be encouraged to do the right thing, and that might be part of that possibly. Okay, a couple of other questions. So one question actually that I think is quite interesting is the kind of at the individual level. So I'm going to try and pick up some out here. So Owen Schaefer asked the question, you know, what does this mean for us as individuals, us being kind of people who are offered boosters? Who, you know, given that I think all on this call, the majority of people on this call agree that these booster campaigns have the potential and in fact are exacerbating global inequality, as well as not dealing with the pandemic. What does this mean for individual people who are offered these things? Does you know, what are the morals at the individual level?
Well, perhaps just an initial comment on that. But it's at the individual level in countries where boosters are being offered, it is much more complicated because you need to understand more about that dose. And what may be the situation in some countries is that doses are near to expiry, that there isn't any way of actually redeploying that particular dose to another country at that point. These are decisions that have to be made at governmental and international levels. We shouldn't be putting the responsibility onto the individual in our populations to make these decisions. Having said that, I think from the public health community, there is certainly, I think, a moment where we should be calling political leaders to account over this, just in the way that the discussion has been going here, that for the vast majority of people, there is no evidence that a booster will make any difference. I think there is some emerging data that there may be some individuals who may benefit from an additional dose, particularly some of the immunocompromised populations. And that, I think, is something which does need to be taken into account. What we don't want to do is to end up with people who really do not have sufficient protection being denied a booster or a third dose in order to make sure they are protected. But I think there is definitely a wider question for the governments about how we can redistribute vaccines. But those have to be done in a way that makes sure that products arrive at another country still with plenty of time for them to be deployed before they expire. And that requires planning. And I don't think we should be making our populations have to work out these individual decisions themselves. It has to be done at the government level.
Yeah.
Yeah, I can just jump in on that one. I think really from a WHO perspective, we feel strongly that people should follow the policies and recommendations at the individual country level. That's where the authority lies. For people, it shouldn't be up to individuals to be trying to sort this out, whether they should or shouldn't take the booster dose or, you know, a third dose. And there are certainly some circumstances that are very bespoke circumstances, immunocompromised people, potentially for some risk groups, for some types of products, the primary immunization may not be performing the way that the clinical trials demonstrated and is exerting that public health impact that we're seeing. So we're certainly not saying that there's no situation in which an individual might have need for a third dose, but it's not at the individual level to be making these decisions of do I take it or don't I take it. I very much agree with Andy. This is actually at a government level. It's at a policy decision level of governments, and products can't just ship from one country to the next. Shifting products around, it's really important, the expiration dates, as Andy said. And this has there's a lot of, incredibly goodwill on the part of high income countries who have donated hundreds of millions of doses. But the question is, are those doses coming now? Are they going to come in the short term, or are these going to be doses that are going to come through in the second half of 2022 when the urgency is sort of in the here and now? And so the expiration dates on these vaccines are really, really important. Country programs just can't get a shipment of vaccine and have deployed the whole thing in 2 weeks when they don't even know with sightline that the product is going to come. So these are the real operational issues that make it very difficult for any country, frankly. And it's the low-income countries that are on the front line of it.
Okay. Lots of questions coming in now. So one question that's been asked a couple of times is about, should we be thinking of this in terms of the shipping of samples which may be near to expiry dates, etc., from rich countries to poor countries, or should we be focusing on manufacture in low middle income countries? So that's, given that it's been asked a few times, maybe someone could have a go at answering that question.
I'll jump in on that one.
Yeah, Yodi.
I mean, I think Kate referred to it a little, and I think also so did Andy. And I think both of them in their previous answers have actually hit the crux of the matter, to my mind, with the push for boosters and various things going on at the moment at a political level. Is very much about vaccines that have been hoarded, that have been stockpiled, and that countries are now pushing into people's arms. And Kate is absolutely correct. From an Africa perspective, we are beginning to see countries donate vaccines that have 6 weeks, a few weeks left on them. There's different products coming into countries all at once. We have Pfizer, Moderna, Johnson & Johnson, AstraZeneca, all coming into countries, coming into health systems that are already under strain, countries that are currently battling a third wave with Delta. And yet they're expected to manage these different products with different cold chain requirements, some with ultra cold chain and some with short lives and short expiry dates. So we have to see it from both perspectives. Countries cannot dump their vaccines that they chose not to donate earlier on in the crisis, when Dr. Tedros and various other leaders around the world were saying, donate now, a vaccine donated now will save lives. The 1 million lives that have been lost since June, as Andy said in his opening remarks, could have been saved had they sent those doses then. They held on to those doses in the hope we might need them. What do we do? Do we follow the populism and the nationalism, or do we actually do what is ethically and morally right and save the collective as opposed to ourselves? And so now we have a situation where, yes, countries do need to donate vaccines and donate their doses, but they can't donate the ones with short shelf lives because logistically that is a nightmare. And they also cannot send them over to African countries, other low-income countries, and then have them expire, which is what is beginning to be suspected on our shores. So then they don't expire in Ohio or in Canada, but they're expiring in Africa. So it's pesky Africans who don't know how to vaccinate. That is what the narrative will be. And I think it's also important to note, something that both previous speakers have said. I think a lot of this has been about narrative. When Kate did her presentation, the slides, which were brilliant, by the way, and I would really love a copy if I may. When she did that presentation earlier, she spoke about if we vaccinated X number of people by yesterday across the world. I think if that had been communicated, if we had been in a time where the messaging was right, this global governance structure for pandemics, both for today and to prevent future pandemics, has been sadly lacking in this moment. So should we produce more vaccines or should we share vaccines? It is not either or, it has to be both and. We have to do both, but in the short term, we have to share as many as possible with as long a shelf life as possible immediately. And that is the right, the morally, ethically, and epidemiologically correct thing to do.
Okay, so I think we're kind of we're at sort of a lot of agreement here. It'd be quite interesting to on to what can be done now. So maybe keep you on the spot, Yodi. I mean, one of the questions from Nadim Hassan was...
Mike, would it be helpful if I just address the question about manufacturing, which was in your question, which,
yeah.
I mean, because I think it's a really important issue. It may well have been that if we had more manufacturing capacity in Africa before the pandemic, then we might be in a better situation than we are today, because there could have been some of the vaccines being manufactured there. I think the challenge at this moment is that the constrained supply is likely to be at least the next 6 to 8 months. And to set up manufacturing today, we wouldn't have things online for at least 6 months to a year. So I think that's the challenge. Manufacturing in Africa is not the solution for the next 6 months. It may be very important as a longer term solution. And so we have to do all we can to make that move. But it's not going to save lives in the next 6 months. And so that's why we have to have different solutions today.
However, about 8-9 months ago, when we started this conversation, I remember chairing and hosting a meeting 9 months ago where we had this very conversation. That is the exact argument we were given by manufacturers. This was the argument that was being put forth. Oh, it will take 6 to 9 months. Therefore, there's no point doing it. Let's share doses. And there is an opportunity in this crisis. And the best time to do something was yesterday. Next best time is now. We must start manufacturing, because clearly COVID and Delta variant have shown us that we're in a really precarious time as a global community. We don't know where the next threat is coming from. We have underestimated this threat. We've been unprepared as a global health community, and we've failed, as Andy said earlier. So we need to prepare those parts of the world that are weakest right now for what may be coming, given the fact that the global community has decided that this is definitely an individualistic moment and we don't care about others. Australia, if I use that as an example, because of regional production in Australia, they have saved the Pacific Islands. You know, many of you have heard me say my second home is in Fiji. The other half of my life is Fiji. And the Fiji Islands had the worst per capita, Kate smiles, had the worst per capita number of cases a few months ago. But Australia, because they had regional production of AstraZeneca, because there was this ridiculous notion that Australians didn't want the AstraZeneca vaccine because of this. Anyway, let's not get into that. No, they didn't want any, they refused to give it to anyone under 65. All of those vaccines went to Fiji, and we were able to deal with that crisis in Fiji. But what did that? We were not dependent on global supply. We were dependent on literally a short hop between Nandi Airport and Sydney Airport, and they got those vaccines across. So that makes your case for production. We need to start it now.
Thanks. So I'm going to give you advance warning of the question after next, and then I'm going to ask you the next question. So the question after next is going to be thinking about Andy's sort of new landscape that we need to work towards, to future pandemics, what pandemic preparedness and so on is, what do you think some of the key elements of that landscape are? I think that's the question after next. This question now is one that's been asked by Nadim Hassan, which is, given that most countries vaccine interest and the whole range of just reasons for that, as you said, Yodi, what plausible political routes do we have now available that could shift some of the incentives of governments to get them to move in a more pro-equity direction in the short term? Are there any levers that we can pull?
Well, first of all, we can put women in charge of the world.
It was meant to be, I meant short term immediately. That's absolutely right, of course. But, today.
Kate, you were going to say something.
Well, I think it's understandable that national leaders are first and foremost responding to the needs of their country. It's who put them in office, and it's who they are responsible to. But I think what was missing from this is a very clear understanding, in spite of heroic efforts on the part of hundreds, thousands of people to try to explain it, is that it was never going to work. you can try to immunize your own country. And I think Delta has basically been the example that it's not going to work if you try to go it alone. And I don't think that politically the sort of messaging out into communities was strong enough or clear enough about what the objective was of the vaccines as one measure in a portfolio of interventions. And it was never intended to be the means to stop the transmission of the virus. You know, early on, we heard lots of terminology that was thrown around that I think really was sort of misunderstood. Oh, we're gonna immunize 60% because we're gonna get to herd immunity. And I think in the lay public, when people talk about herd immunity, I think they think it means, when is life going to get back to normal? They don't really understand what herd immunity is. It's just a code for, oh, then life is normal again. And I don't think there was enough of speaking truth to power and speaking truth to the community that was never probably ever going to happen. And obviously this pandemic, you know, has taught us a lot about the virus and about transmission and about what the vaccines can do. But I think the plausible sort of roots right now is I think high-income countries are seeing the reality, which is we're never going to end this thing unless there is equitable distribution of the vaccines. And so there is a national interest in assuring that the world gets vaccinated. And that means swapping the order of supply, putting your shipment further down in the queue so that COVAX and AVAT can get their shipments. So I think that's one thing. And I think the second thing is we are seeing very much in high income countries a demand ceiling, is that those who wanted to get vaccinated had full access to get vaccinated. And now it's getting harder and harder to get the vaccination rates above where they are. And obviously there's huge variability in countries, again, because there is, I think, a lack of acceptance and a lack of understanding that this is not going to end until there's much higher vaccination coverage. And I do want to just touch on the manufacturing. It would be a shame if people left this not knowing there is a huge effort to stand up manufacturing, not just fill and finish in the African continent, but actual manufacturing with a training hub on mRNA vaccines that's being stood up now in Cape Town, South Africa, where people from countries around the world, primarily in Africa, come and get trained and would have the full elements of what is needed to go back to their country in order to establish manufacturing there. Over and above COVID vaccines, vaccine manufacturing the African continent does not produce its own vaccines, even for the routine immunization program, save for a few examples, yellow fever, for example, from Senegal. So this is not just about pandemic preparedness and just about the vaccines for outbreak pathogens. It's about supply security domestically on every continent. And I think this has been a huge lesson for many countries, including some high-income countries. Canada does not produce vaccines. I think that's an example of a high-income country that had a difficult experience at the outset of this supply trajectory as well. So I think those are some of the things that need to be addressed and will change.
Great. Thank you very much. Anyone else want to comment on that question before I move on to the other one? No. I mean, I find it, as an ethicist, I find you're right, but I also find it, what change will happen when the self-interest of high-income countries just happens to coincide with people who are interested in equity want to see happen. That's that's quite a slightly depressing thought, really, but probably right. Okay, so it'd be good to have each of your thoughts on this bigger question about the future, as opposed to which is, Andy, you mapped out this sort of idea of the need for a renewed and a new kind of form of a global governance landscape, as it were, and in which we might respond differently when we're confronted by another pandemic, and hopefully we might be able to cut short the life of any potential pandemic. But what are the key elements of that landscape? What do we the world, as it world leaders and countries need to do? What do we need to put in place? So any sort of thoughts on that would be really welcome from all of you. Maybe Andy, you mentioned it. Perhaps we could start with you.
Yeah, I mean, I think in some ways I feel a bit pessimistic about it, because I feel to some extent that the experiences of this pandemic are likely to make nations even more entrenched. And you have to remember that this is in the situation of a pretty good pandemic with a mortality less than 1%. Now, we are clearly threatened, but it's not like might have happened in previous pandemics. So now, if we look back over history, we've had pandemics with 50% mortality. If the coronavirus had been the MERS coronavirus rather than this one, that had a 35% mortality. I can't see a situation where domestic politics would say, oh, actually, we should think about the global equity. I think the focus will inevitably be national. And that's something which we have to think very hard about, not framing everything in the way we've experienced in this pandemic, but what other scenarios might be. And perhaps the obvious solution, the reason why we have a problem, is because of the supply constraints. And the challenge there is that where you could get better prepared to have sufficient supply for the world, the difficulty would be if it takes 20 or 50 years before the next pandemic, maintaining facilities on the scale to manufacture vaccines as we need for the world today. It's just not possible to keep those facilities going in the inter-pandemic period. So I do feel a bit pessimistic from what we've experienced so far. What can we do to start moving in that direction? I think we definitely need to make sure that there is much better information. I think Kate made this point already. I actually also think that WHO needs strengthening. My feeling is WHO was weakened over the last decade or two. It needs to be a much stronger institution. I mean, people have actually talked about having a global public health pandemic institution set up that could better lead political leaders. To me, that is WHO. And WHO needs to be a much stronger international organization and supported better by governments, so that they look to WHO to help with some of these decisions in the future. And I think your comment about having some international governance, that has to happen in the inter-pandemic period to make sure that people are signed up to a new approach to how we deal with pandemics. And there will be a lot of unpicking after this one. The unpicking of what has the failure to distribute vaccines equally done to the global economy. I think we will start generating better evidence that supports more equitable distribution going forwards. But as I say, I do feel a bit pessimistic that there is a risk of this being more entrenched, at least in the memories of current leaders. And that's both in high-income countries and in low-income countries, who are going to be looking very differently about pandemics in the future. So, as I say, I feel a bit pessimistic, but the only way that we can change this is by having, I think, stronger international institutions.
Thank you very much. Kate, do you have some thoughts?
Yeah, I share Andy's views about what needs to happen, but I don't share the pessimism. I think it's extraordinary. We have had, scientific advances in something that is just, magnificent. It's hard to know what words to use to describe that. And when you think that we've been at vaccine deployment for 9 months, and the world is at where it's at almost a 50% coverage around the world. I mean, that is, notwithstanding all of the inequity, I think we also have to see the way in which the world did come together to solve some of these issues. But if I can add on to Andy's list, I would add a couple of things. I want to say civil society, and embedded within civil society, the strength of civil society is that it must command a fifth estate, a journalism, a communication that is about real evidence, it's about real data, it's about facts. And I think we have to address the misinformation issue in a much stronger way than we have. And we hold certainly high responsibility on some of the social media platforms for their capacity to either constrain the distribution of misinformation or their inability or lack of choice to do that. And it's not about free speech. You're not allowed to run into, a hotel and scream fire and say you claim, and cause something terrible to happen and claim that you had a free speech right. So of course, that's I'm not an American, but that's a very US perspective. Transparency is, I think, the other thing. I think we have to call for a freeing of the data. Freeing of the data from manufacturers, from countries, from governments. We have to understand what went on in order to build a better response in the future. I think that commitment to science is the fourth thing that I would like to highlight. And I would really like to, I know we will have people who will unpick this, but there are choices that have been made and will continue to be made that are driven largely by political views rather than the science that is available at the time, or even anticipation of what the science will show. And I think we need to get back to that very firm commitment that the decisions will be driven by science. And then the last point I just want to highlight is the generational impact, that there are young generations that will not recover from this over their lifetime. And what I mean by that is the loss of income, the loss of advancement, the loss of education, in some countries, especially on girls, being taken out of school, early marriage. And there is a whole generation that will be affected deeply by what has happened over the past year and the recovery into the next year. And I think that's where a huge amount of attention needs to be paid to not allow them to be on a different trajectory than they would have been if this economic implosion, social implosion had not happened. And I don't want those young people to be forgotten, even as we're facing, the protection of older people from acute disease and death. It's really that generation that I think is going to be the most worrisome and will set the stage for some countries in the future and perhaps some continents.
Thank you very much, Kate. So given limited time, I'd like to move on immediately to Yodi. I don't know, one of the things that, one of the questions we've had from Dorcas Kamuya in Kenya is, whether there's, what role you think there might be for African governments, what should African governments think about this, and what are their responsibilities? But just if you have time to say something about that, great. But I'm interested in your thoughts about the kind of requirements at the global level, particularly.
Thank you. I really think both Kate and Andy have really said it all. I mean, from my perspective, I think really we need to address the root cause of all of this. We're talking equity here, we're talking the ethics, and we're talking about power. This is not just about science, this is not just about health. I'm really pleased that Kate mentioned the sort of wider impact, the socioeconomic, the education, the girls being sold into sex slavery and into marriage, the burden of other diseases on the increase, routine immunizations on the decrease across many countries in the world, mainly Africa and other low-income countries. But to address the inequality inherent in this global health system or the global system, this order that we have, we really need to rebalance the power structures that underpin them. It requires, I would say, a bottom-up approach that would be grounded in the experience, voice, and ideas of, as Kate said, the next generation. It requires a top-down approach that changes the power structures from within, changing the world order, which we need to do structurally. I'm heartened also, I'm slightly pessimistic and slightly optimistic. I mean, recently Dr. John Nkegasong was nominated to PEPFAR, which is beginning to answer the questions around decolonization that we've all been screaming around. Somebody who understands, how it really feels at ground zero, and not just somebody who parachutes in and tells us what to do and how to do it from their position of privilege. We require a shift in our environment that holds powerless in check, because if we weren't powerless, we would have had vaccines in this instance. We need to forge new networks. We need to tap into and promote the voices of women and young people, and especially those from the African continent, from Latin America, from parts of Asia, and establish true alliances that break down the divides that exist currently between us, the divides between the powerful and the powerless. We need to deal with inequality, and we need to deal with the ethics. I really liked the topic of this webinar, because the ethics of this entire the trolley problem for me, that it immediately brings to mind the individualism versus the collectivism. I really think that we need to have a greater debate around it and on a global stage. There needs to be, after World War II, the world got together and put together the Bretton Woods institutions. They came forward with a solution. They realized that they needed to face this threat collectively. And I agree with my colleagues that we need to come together as a world, but we need to do it not so much as from a them and us situation. We need to do it in a together situation. We need a stronger WHO, but the solution is not just within WHO. We need an umbrella organization, or not maybe another organization, but maybe a platform, such as, when UNAIDS was created after, during the AIDS pandemic, that deals with the socioeconomic, with the education, with the gender aspects, with the equity aspects. And there needs to be a much deeper conversation had around some of the issues that we've discussed today.
That's fantastic. Brilliant way to end this webinar. I really like the idea that global justice is the trolley problem of the 21st century and beyond. So let's try and deal with that problem. That would be great. Thank you very much for our wonderful speakers today. All of you are incredibly busy, particularly at this time, and I know that you've had to give up other things to be here. We really, really appreciate that.